Hello guys, welcome all of you to today's Pharmcast. I'm Dr. Ranjan, your pharmacology faculty at Mero. And today guys we'll be covering the second part of antimicrobial drugs, that is antifungal, antiviral, etc. Antibiotics I have covered in the first part, right? So antifungal drugs guys, to begin with, amphotericin B, its mechanism has been asked couple of times. And they do ask you, what is the target? Is it cell membrane or cell wall or nucleus, right? These are the options. And all of you know your answer was cell membrane. So as you know, we are revising according to the Touch Pharmacology book, and we are on page number 41. And cell membrane, as you can see, I have marked it in red color because it is important. Second, the drug of choice, where amphotericin B is drug of choice, these have been frequently asked. So if there is a systemic fungal infection, like for example candida causing meningitis or blood infection, candidemia, automatically your answer becomes amphotericin B. Now, say if it is candida causing vaginal infection, for example, right, vulvovaginal candidiasis, then we use oral fluconazole. But if it is systemic infection of candida, even I'll be using amphotericin B. Kala azar, mucormycosis, cryptococcal meningitis. This was asked recently in the fmge exam as well, cryptococcal meningitis. And Tellaromyces was also recently asked in the INI-SET exam. So these are uses of amphotericin B. Side effects are commonly asked. Two side effects are asked. One is hypokalemia. So either they ask you hypokalemia is seen with which antifungal. Second, they ask you potassium chloride can be used or is used with which drug, amphotericin B. Second side effect, nephrotoxicity. They ask you which drug causes nephrotoxicity, amphotericin B obviously. Then they ask you how can I possibly prevent this nephrotoxicity. And one is by preloading the patient with normal saline. And second, using the liposomal combination of amphotericin B, LAMP, liposomal amphotericin B. Now coming to second class, azoles, their mechanism has never been asked, but they can ask you how they act. They inhibit ergosterol synthesis in the cell membrane. Fluconazole is frequently asked. It is drug of choice for candida, but remember only for mucocutaneous candidiasis, plus it is active only against albicans species. So the most recent PYQ that was asked, it was regarding which match the following is not correct, right? Incorrect match the following, and it was fluconazole and candida glabrata, right? So it is not effective against glabrata, parapsilosis, etc. It is only active against albicans. Itraconazole, it is drug of choice for endemic mycosis, dermatophytes, sporotrichosis. Voriconazole, it has been asked recently, invasive aspergillosis, it is drug of choice. Posaconazole, there are two MCQs. They've asked you which azole is effective against mucormycosis. So as of now, there are two azoles which are effective, posaconazole and isavuconazole. Second MCQ which was asked on posaconazole was which antifungal is used in GVHD to prevent fungal infection. Again, your answer was posaconazole, right? Other than that, guys, terbinafine is not that commonly asked nowadays. Echinocandins, the only MCQ that I can recall in PYQs was an image-based MCQ, where in an image of a fungal structure, they had marked beta-glucan synthase, and they asked you which antifungal drug possibly acts upon this structure, and your answer was an echinocandins. Griseofulvin, there are two MCQs. One is drug of choice in tinea capitis. It has been asked, carrion or boggy swelling, it is also known as, right? And image-based MCQs asked where they had given an image of scalp, and it was a case of tinea capitis, which drug is used, griseofulvin. Another MCQ that was asked, not within 5 years, but around 7 to 8 years back, they had asked you, which of the following antifungal drug should be taken with fatty food, right? And your answer was griseofulvin because fatty food increases absorption, right? Now let us move on to page number 42 in the Touch Pharmacology book. And page number 42, guys, is about antiviral drugs in this one page. Non-retroviral drugs, anti-herpes virus drugs. Let's revise quickly what they ask. See, acyclovir, ganciclovir uses are asked. So oral valacyclovir more than acyclovir is preferred for treatment of HSV and VZV. IV acyclovir is preferred only in severe cases like HSV and encephalitis. Second, oral valaganciclovir more than ganciclovir is drug of choice for CMV retinitis. IV ganciclovir would be preferred only if there is a high risk of blindness, right? Now, side effects which they ask commonly are acyclovir causing crystalluria, ganciclovir causes bone marrow suppression. Second drug, foscarnet, The only MCQ that has ever been asked in foscarnet is, what is the drug of choice for acyclovir resistant herpes? Your answer is foscarnet. Pseudofovir, the only MCQ that has been asked, what is the drug of choice for recurrent laryngeal papillomatosis? Pseudofovir. That's it in herpes virus drugs, guys. Anti-influenza drugs, the second one in page number 42. The MCQs in influenza, they are limited only to neuraminidase inhibitors. They ask you what is the drug of choice for influenza or bird flu. Your answer is oseltamivir. If they ask you what is the drug of choice in case of oseltamivir resistance, your answer is zanamivir. That's all you need to know in influenza. Anti-hepatitis C, hepatitis B. What they want to know, if you look at last 5 years, the MCQs which have been asked is about names of the drugs, which is a specific drug in hepatitis B and which is a non-specific. Means non-specific drug means an anti-HIV drug used in hepatitis B. So these are tenofovir, clavudine, talbivodine, lamivudine and emtricitabine. These are the anti-HIV drugs used in hepatitis B. So this is what they want to know from you, which are drugs which are not specific for hepatitis B or which are anti-HIV drugs used in hepatitis B. Hepatitis C, if you look at last 5 to 10 years, MCQs have not been asked. The MCQ are concentrated only on one drug here, that is ribavirin, but it is not uses. The MCQs are not related to use in hepatitis C. Rather, it is used related to treatment of RSV, respiratory syncytial virus. So, what is the MCQ? They've asked you what is the drug of choice for RSV treatment, right? And your answer is ribavirin, inhalational ribavirin, right? Second MCQ, they've asked you what is the drug used for prophylaxis of RSV infection, and it's a monoclonal antibody called as palivizumab. Now, direct acting antiviral drugs, just go through them. They've never yet been asked, but they might be asked in the coming exams. Now, antiretroviral drugs are always asked, right? And the NRTIs, nucleoside reverse transcriptase inhibitors. So all are nucleoside reverse transcriptase inhibitors, what we are discussing in this class A, except tenofovir, which is a nucleotide reverse transcriptase inhibitor. So that is one MCQ they ask, which is a nucleotide, right? And that is tenofovir, right? Zidovudine, nowadays, guys, it is not asked. And if you look at 5 years, it has never been asked. But before 5 years, they used to ask mostly about bone marrow suppression or anemia. Which drug causes? It is zidovudine. Lamivudine or emtricitabine and tenofovir. These are least toxic drugs in this class and they are more preferred in the regimen. And all of you know what is the regimen, and for regimen, please follow the PSM lectures, right? Other than this, guys, abacavir can cause Stevens-Johnson syndrome. It is sometimes asked. NNRTIs, MCQs have not been asked in the last 5 years because NNRTIs are now third line drugs not used in India. Nevertheless, what has been asked before 5 years is mostly about prevention of perinatal transmission of HIV, where the drug of choice is nevirapine, or which anti-HIV drug can cause fatal hepatotoxicity. It is nevirapine. Protease inhibitors are commonly asked, guys, nowadays. The most recent MCQ. So let us dig into the last 5 years questions. It has been asked on two drugs, ritonavir and indinavir. Ritonavir, what are the MCQs they have asked? They have asked you which of the following anti-HIV drug can increase bioavailability of lopinavir, they had asked. Right, your answer was ritonavir. And the older MCQs, they had asked you which is a booster used along with protease inhibitor. Again, your answer is ritonavir. So ritonavir, it is used as an enzyme inhibitor, a booster, right? So it can inhibit metabolism and increase bioavailability of other protease inhibitors. Cobicistat, which is just an enzyme inhibitor, has been approved to be used with atazanavir, darunavir, elbitagravir. Now this was asked once. They had asked you which of the following anti-HIV drug is used with cobicistat, and your answer was elbitagravir. Indinavir, it has been asked multiple times, guys. Even in the last 5 years, they have asked which anti-HIV drug can cause renal stones or nephrolithiasis. It is indinavir. And atazanavir, the only MCQ that I can recall that has ever been asked is which protease inhibitor will not cause dyslipidemia, and your answer is atazanavir. Integrase inhibitors, they're not that much asked, guys. And if they ask, they will ask about the name of the drug, which is an integrase inhibitor. And you remember raltegravir, dolutegravir. So there is Tegra. Tegra is taken from integrase. Now coming to the page number 43 in One Touch Pharmacology book. Here we have TB and leprosy drugs. And see, if you look at the last 5 years MCQs, they're mostly concentrated in the first line TB drugs, right? And to begin with, mechanism of action of first line TB drugs, they never ask about pyrazinamide or ethambutol. Mechanism is always 100% times it is about either isoniazid or rifampicin. So isoniazid, it is activated by an enzyme, mycobacterial enzyme called as catalase peroxidase, which then further blocks mycolic acid synthesis. There are two MCQs which were asked in the last 5 years. That is, one, they had asked you an image-based MCQ where they had marked catalase peroxidase in that particular structure of mycobacterium, and they had asked which anti-TB drug acts. Your answer was isoniazid. Second MCQ which was asked in the last 5 years was mutation of catalase peroxidase will cause resistance to which TB drug, and again your answer was isoniazid, right? Rifampicin mechanism has been asked. They had asked you which of the following TB drug blocks synthesis of RNA from DNA, which means we're blocking what? DNA dependent RNA polymerase, and RNA polymerase is blocked because of rifampicin base. Second, they ask you about the cidal or static effect. Remember, all first line drugs are cidal except ethambutol, which is static, but they do ask you which is most cidal or most sterilizing first line drug. Your answer is rifampicin. Third, they ask you which drug acts on non-replicating bacteria, which are called as persisters, and there are two, rifampicin and pyrazinamide. These are most active. Most active is rifampicin, followed by pyrazinamide. Third, fourth, they do ask you about which is the safest first line drug in renal failure, and your answer is rifampicin. If they ask you most unsafe in renal failure, then your answer would be ethambutol. Now coming to side effects, guys, if you look at the side effects of first line TB drugs, I have marked these side effects as red color, which means each and every side effect has been asked umpteen number of times. Now pyridoxine, isoniazid, it decreases B6 or pyridoxine that causes neurotoxicity and anemia, and to prevent that we supplement vitamin B6. So in the last 5 years, twice this has been asked, which first line TB drug is used with vitamin B6? Isoniazid. Rifampicin, it causes red, orange discoloration of urine, flu-like symptoms, thrombocytopenia and pulmonary syndrome. Now these two, thrombocytopenia, pulmonary syndrome, if a patient develops, what should be done? It has been asked. I should stop the drug obviously and never ever restart in his entire lifetime. Pyrazinamide has been asked. The most frequently MCQ they ask about pyrazinamide is which first line TB drug can cause gout or worsen gout. Your answer is pyrazinamide because it causes hyperuricemia. Second MCQ they ask you which is most hepatotoxic first line drug, pyrazinamide. And third, they ask you which first line TB drug can cause joint pain. Again, your answer is pyrazinamide. Ethambutol, remember, E for ethambutol, E for eye toxicity. So it revolves all around eye toxicity like optic neuritis or red-green color blindness. Now before we move ahead, so there are two things they ask you about resistant tuberculosis where second line TB drugs are used, and resistant tuberculosis, MDR-TB. See, MDR-TB is when there is resistance to isoniazid and rifampicin. It has been asked multiple times, guys. And what is XDR-TB? When there is resistance to isoniazid plus rifampicin plus fluoroquinolone plus at least one injectable drug like aminoglycosides, right? Now, guys, second line TB drugs, mostly they will ask about new drugs like bedaquiline, delamanid, pretomanid. But remember the new drugs in TB, these are my second priority. My first priority for NEET PG exam has to be always first line TB drugs. After that, my second priority becomes the second line TB drugs. And here, remember with these new drugs, at least remember the red colors which are marked like the mechanism of action or the route. All these drugs are taken by oral route and they are taken with food because food increases bioavailability, right? So these are few points which you have to remember. Anti-leprosy drugs, guys, they are not that commonly asked. Right, and mostly anti-leprosy, if you look at the last 5 to 10 years MCQs, it is mostly about guidelines, not about drugs. So go through the guidelines in PSM. Now coming to the last page, page number 45, where we are going to discuss the anti-helminthic and anti-protozoal drugs. See, anti-helminthic drugs, see, two type of MCQs are asked. One, drug of choice. Second, type of paralysis. So this I have told you in my lectures as well. Drug of choice, albendazole, ivermectin, praziquantel. These three drugs are commonly asked, and so I marked all the drug of choice in red color. Right. So, for example, albendazole is drug of choice in Trichinella spiralis, Antirobius vermicularis, Echinococcus, neurocysticercosis, soil-transmitted helminths. Ivermectin is drug of choice in strongyloids, Onchocerca volvulus. Right, praziquantel is drug of choice in D. latum, intestinal T. solium, schistosomiasis, H. nana, T. saginata. So all of this I have told you, right? Types of paralysis. Remember, tonic paralysis is caused by ivermectin. Spastic paralysis is caused by praziquantel, metrifonate, parental pamoid. Flaccid paralysis is caused by piperazine. If you know this much, your job is done in anti-helminthic. Anti-protozoal drug. The most common protozoa which is asked is either amoebiasis or plasmodium. So let us begin with amoebiasis. See, amoebiasis, for intestinal amoebiasis, there are 3 drugs I use, which you can remember as dip in stool, diloxanide furoate, iodoquinol, paramomycin. Now these drugs, they are not absorbed by oral route, so they only act in lumen. So they are called as luminal amoebicidal drug. So they do ask you which is a luminal amoebicidal drug. Any one of these 3 will be your answer. But if it is intestinal symptomatic amoebiasis or extra intestinal amoebiasis like hepatic amoebiasis, in that case my drug of choice is metronidazole. I can also use nitazoxanide. For hepatic amoebiasis only, I can use chloroquine if metronidazole is not available or it is not indicated or contraindicated in that patient. Now, metronidazole, guys. Metronidazole is a 5-star drug. It's very commonly asked in your exam, and its drug of choice are important. So remember, there is one correction here. I've written here supra-diaphragmatic anaerobes. That is wrong. It is actually infra-diaphragmatic anaerobes where it is used. And it is drug of choice in amoebiasis, trichomoniasis, tetanus, bacterial vaginosis, giardiasis. These are the uses of metronidazole. So the most recent MCQ that I asked you was regarding bacterial vaginosis, which drug is used. And second MCQ, which is asked in the last 5 years, PYQ, that asked you which of the following antimicrobial drugs should not be taken with alcohol. And again, your answer was metronidazole because it can cause what? Disulfiram-like reaction. Leishmaniasis, visceral and cutaneous. Say visceral leishmaniasis, drug of choice is IV liposomal amphotericin B. Whereas oral drug of choice for Kala Azar is miltefosine. Miltefosine is also drug of choice for post-Kala Azar dermal leishmaniasis. Cutaneous leishmaniasis, drug of choice is sodium stibogluconate. So here mostly MCQs are asked on Kala Azar, right? Cryptosporidiasis, drug of choice is nitazoxanide. And remember, another use of nitazoxanide is also drug of choice in metronidazole resistant giardiasis. Both have been asked in your exams, right? Second, babesiosis, treatment of choice is atovaquone plus azithromycin, be it mild, moderate, severe for all cases of babesiosis. Now coming to the last one, guys, plasmodium causing malaria. See, artemisinin group, these are the fastest acting and most potent cyanotocidal. This is one MCQ they ask you. Second, MCQs are asked on usage. What is the drug of choice for severe falciparum malaria? This has been asked in the last 5 years. They are given a case of falciparum malaria where the patient was disoriented, and obviously they are asked which drug is to be used. Disoriented means severe alcid or brain malaria, IV artesunate. If it is a case of uncomplicated falciparum malaria or chloroquine resistant malaria, in that case, for all parts of India, I'll be using artesunate plus sulfadoxine plus pyrimethamine. Right, whereas for Northeast, I'll be using oral artemether plus lumefantrine. Chloroquine, on the other hand, it is drug of choice for malaria. If it is chloroquine sensitive malaria, like Vivex malaria, if it is chloroquine sensitive. But to add on to chloroquine, I'm also gonna use primaquine for 7 days or tafenoquine for once for radical cure. So they had asked you, what is the use of tafenoquine in malaria? They had asked you this, and your answer was for radical cure in Vivex malaria was the answer, right? Side effect of chloroquine, bull's eye retinopathy has been asked. Corneal deposits have been asked. So these are 2 MCQs which have been asked with respect to chloroquine. Now, malaria in pregnancy, remember, if they ask you what is the drug of choice for malaria in pregnancy, trimester is not mentioned, right? That means they're asking about first trimester. Malaria in pregnancy, nothing is mentioned, go for chloroquine. If they mention drug of choice for chloroquine resistant malaria or falciparum malaria, trimester is not mentioned, that means they mean first trimester, go for quinine. If they specifically ask you second and third trimester in falciparum malaria, then go for ACT or artemisinin combination therapy. So guys, with that, we are done with the second half of antimicrobial drugs, and this covers the entire topic of antimicrobial drugs. And as you know, every time, I covered some doubts that students, they do ask me every week. And the last week a student asked me, sir, all my batchmates, they have started revising, but I am yet to begin revision. The reason being, I'm doing one major subject which is left, and I'm kind of feeling FOMO that all are revising and I'm not revising. What should I do? Now, see, it's obvious that we are already towards the end of Jan, and it's high time that you begin revision, guys. Now, if there is something left, then just do one thing. Give every day 1 hour for that particular. Let us say your medicine is left, or surgery is left, or obs gyne is left, or pharma is left, or any subject is left. So don't study that subject for 5 days, 6 days. Rather, every day just give 1 hour to that subject, right? And now, since the time is less, in Marrow you can use the revision videos. This is the time to use revision videos if you have not yet finished any subject. And suppose you are studying 10 hours a day, then 1 hour you can just do that subject, and 9 hours you can focus on revision, because guys, it is high time. It's high time to begin revision, and you are right to have that FOMO. The reason being, if you don't revise, right, you will not clear the exam, no matter how much well you have studied in the first reading. Because revision is what is going to consolidate whatever you have studied earlier. Because practically speaking, if I'll tell you that not revising is equal to not preparing, are you getting my point? That is how important revision is in any competitive exam, right? So revision makes you better, revision makes you sharper when you go ahead further. And second part, someone asked me, sir, in this last leg of revision, when I'm going towards the exam, should I only do theory or should I only do MCQs, right? So guys, it has to be a mix of both, remember, because you have to revise theory so that you can solve new MCQs, and you have to revise MCQs as well. You have to do MCQs, practice MCQs as well, for a simple reason, not because the MCQs will be repeated and you will mark the answer. No, that's the wrong conception. You'll do MCQs, the reason being your exam is MCQ based, and for that reason, till the very last day of exam, I need to keep practicing MCQs. So practicing MCQs should not be something new to me. So on the day of exam, I should go and start solving MCQs as if it is a day-to-day affair for me, right? And nevertheless, guys, I have told this time and again. There are many students, they ask me, sir, now should I change my nocturnal lifestyle into day lifestyle? The reason being, the exam would be on day, and I study throughout the night, and I'm awake throughout. I'm sleepy throughout the day. I sleep in the daytime. Now, it usually happens. Now, if you are someone who likes to study at night time, it does not mean you are wrong. It's just that some people, they cannot concentrate well in daytime, and I was one of them. I would study from until 5 o'clock, 6 o'clock in the morning. I'll study until 5 or 6 in the morning. Then I would go to sleep at 6 o'clock, wake up at 12 or 1 o'clock, and then my day would begin. And why did I follow this? Because usually what used to happen with me, I would not realize how if I get up at 8 or 9 o'clock, how it becomes 1 or 2 o'clock without any productivity. I would not know. So I realized, it is not advisable, but see, I had to crack the exam, and I had to do whatever I had to do. So many of you might be in the same boat as I was there. But at that time, it was difficult for me, right, to bounce back, to change my nocturnal lifestyle. But now that I know what can be done. If you want to change your nocturnal lifestyle into day lifestyle, then you can use melatonin. Melatonin, it's not considered as a drug, it is considered as a food supplement, and it is also available in Amazon, right? It's because it's a food supplement. And 3 milligrams you have to take just after the dinner. But remember, it takes 2 hours to produce effect. It won't make you drowsy. It's just that when you go to bed after, suppose at 8 o'clock in the evening, I had my dinner, I took a tablet, and then I have to go to the bed at 10 o'clock. And when I go to bed at 10 o'clock, it would be much more easier for me when I close my eyes, then I will fall asleep. The good thing is, it won't cause morning hangover, or it won't cause drowsiness in the morning. So even the day before exam, if you are having difficulty in sleep onset because of anxiety, you can try a tablet of melatonin. So guys, that's all from my side, and we have covered almost all the major topics in pharma. The remaining one, Endor, SPGIT, Otacoid, etc., I will be covering in due course of time, and I'll post the schedule for this week as well. So guys, I wish all of you all the best, and keep your hopes high, keep positivity in your mind, right? Don't run for anything new in these last 1.5 months, and God be with you guys. Take care, lots of love and blessings. This was Dr. Ranjan with you, your pharmacology faculty at Mero.